morning all. So, we have in the last sessions we have completed the management of dehydration, how to assess dehydration, respiratory emergencies we have completed. Now, we are coming to the conclusion of our pediatric advanced life support lectures. So, the final one is approach to shock. We have almost covered the hypovolemic shock yesterday. So, management aspect there is no other changes, but there are certain things that you need to know. We have already discussed in the adult resuscitation regarding shock, what are the different types of shock, what are the causes for different types of shock. And again there is certain small differences when you compare it with the adult from the pediatrics. So, that we need to understand. Okay. So, as you are all aware, shock, it is basically, you can see that the shock is basically classified into 4 types. Simplified version is 4 types. You can call it as distributive shock, hypovolemic shock, which one of the major reason for the hypovolemic shock is the dehydration, acute diarrheal diseases which we have discussed yesterday, cardiogenic shock and obstructive shock. So, these are the different types of shock. So, among distributive shock, you have septic shock and anaphylactic shock, and you have neurogenic shock. So, when you are writing for an exam and you have been asked to classify shock, you can classify this way, which is better. Rather than writing septic shock, cardiogenic shock separately, you can say it as first as distributive shock. Under distributive shock, you can have septic shock, anaphylactic shock, and you can have the neurogenic shock. So, septic shock, as the name itself says, that you have an evidence of a microbial infection either clinically or microbiologically proven, and the patient has got an hypotension. So, that is what a septic shock is all about. So, septic shock, there is an evidence of infection. Suppose the patient is coming in with fever, you are examining him fever, high grade fever since last 2 days, and you are examining him, there is hypotension. So, clinically you can tell that this patient is in septic shock. Okay. So, septic shock, again as I said, when does a patient will have this hypotension? When the compensatory mechanism fails. So, in all these shocks you can have compensated shock as well as hypotensive shock. You understood that? Yesterday we told that in hypovolemic shock, when the patient is having hypotension along with dehydration, we will call it as hypotensive shock. But the body will have some compensatory mechanism by which the body will try to utilize whatever be the available resources and will try to perfuse the vital organs, especially brain, heart, kidneys. So, as a result, there is no hypotension as such, you are not able to see hypotension, but there is shock stays to the tissues. So, shock, as I told yesterday, shock, what does it mean? It is not hypotension, it is, you cannot use shock is equal to hypotension, you cannot use that, but shock can cause hypotension. So, the body will try to compensate this shock, and if the BP is maintained above the 5th percentile, whatever we have discussed, 70 plus age into 2, that will be the systolic BP. If BP is maintained above that, we can call that it is a compensatory shock. That doesn't mean that this patient is not having fluid deficit. That doesn't mean that. What is that? The body is compensated in a such a way that the body is trying to maintain the vital organ perfusion. So, if the vital organ perfusion drops, what will happen? Organ dysfunctions comes. So, the body is trying to prevent that. So, if the compensatory mechanism fails, then the patient will go for hypotension as well as shock. Shock is already there and there will be also hypotension, and vital organ perfusion will be getting affected more. So, for all these shock, you can have and body can have a normal compensatory mechanism by which the body is trying to not to go for hypotension. The body is trying to compensate, not going for a hypotension. If the compensatory mechanism fails, the patient will go into hypotension. So, compensated shock and hypotensive shock. So, that is a simple terminology. So, septic shock, as I told, it is a distributive shock. So, there is an sepsis, microbial infection, and as a result there is lot of inflammatory markers, cytokines being released in our body. So as a result, what will happen? The most important reason why there is a septic shock, it is problem because of the peripheral vasodilatation. So that is the distribution. That is why it is called as a distributive shock. So it is distributed. So it is distributed to the peripheral circulation, and as a result there is a peripheral vasodilatation. So because of this peripheral vasodilatation, what is happening? What is your blood pressure? Blood pressure is basically your cardiac output into your venous return. So here cardiac output is not an issue right now, but venous return is decreased. Why venous return is decreased? Because blood is getting pooled in the peripheral circulation. You understood this concept? Clear? So, but cardiac output also can be in trouble. Suppose the patient is having a sepsis along with myocarditis. Imagine that an infection has caused, it is causing sepsis, and the same microbe is affecting the heart also. So, myocarditis, what it will cause? It can cause decrease in contractility of the heart. So, if the contractility of the heart also decreases, the cardiac output will decrease. So, as I said, one patient can have different issues. They can have associated septic shock and also cardiogenic shock. So, it can be a combination. But usually what you need to remember is that if it is a septic shock, usually what you will get is something called as an warm peripheries. Why warm peripheries? Because blood is getting pooled in your peripheral circulation. So, when is getting pooled in your peripheral circulation, what will be the management plan for us? Our management plan for any septic shock will be, initially what you have to do, you have to give fluid bolus, balanced crystalloids. Whatever we have discussed for dehydration yesterday is the same fluid of choice what you need to give. So, first you have to give that. Then the next thing what you have to see is that if the patient is not improving after giving one of your drug means normal saline, then you need to start an agent which is causing vasoconstriction. So, the agent of choice is noradrenaline. So, that is why in septic shock the drug of choice is noradrenaline, because noradrenaline is a drug where the predominant action of noradrenaline, you know that there is beta receptors, beta 1, beta 2 receptors, alpha 1, alpha 2 receptors. These are a lot of receptors. So, noradrenaline is a drug which has got predominant action in the alpha receptors. Alpha receptors is situated in your blood vessels. Beta 1 in your heart, beta 2 in your bronchioles. So, beta receptors are basically in your respiratory system and in your heart. But alpha receptors are there in your peripheral blood vessel. So, noradrenaline is a drug that has got maximum effect on the alpha receptors. So, alpha receptors, what it will do? It will do vasoconstriction. So, as a result of vasoconstriction, what will happen? There will be improving in the venous return. So, the blood pressure improves. So, what I am discussing is just the hypotension management. So, general management is stabilizing the airway breathing. The patient is tachypneic, the patient is hypoxic, you need to supplement all those things. I am not discussing to those aspects. You have to remember that whenever you are seeing a patient with sepsis, there are certain things that you need to do. You are suspecting a septic shock, there is something called as sepsis bundle. You need to follow a certain protocol called as sepsis bundle. So, what do you mean by sepsis bundle? Whenever a patient with suspected sepsis comes to you, you need to do certain things within 3 hours of time. So, among that, the most important one is that if there is evidence of hypotension, you need to give a balanced crystalloid at a rate of around 20 to 30 ml per kg in the first 3 hours. But in a children, what do you need to do? You need to give a little bit more faster, maybe in the first 1 hour or within the first 15 to 20 minutes, depending upon the severity of the hypotension. You need to give a fluid bolus. The next important thing, you have to measure a serum lactate. So, sepsis bundle, when you say sepsis bundle, 1, if hypotension is there, you have to give normal saline. Second one is measure serum lactate. Then third one, draw blood cultures. You have to draw blood cultures and you need to start a broad spectrum antibiotic. So, this is what you have to do within 3 hours when a patient with suspected sepsis is coming to you. But if the patient is with a septic shock, okay, I am telling this is just for sepsis. That is septic shock, you have to be much more faster. We have to give it as early as possible. For a normal sepsis patient, we can within 3 hours is what it say. But if it is a septic shock patient, you have to do everything little bit faster. You have to start giving the antibiotics faster. You have to draw the blood culture, everything faster, because already there is hypotension. Okay, you have to understand that. So, this is what is called as sepsis bundle, sepsis 3 hour bundle. For all patients with sepsis, What is basically sepsis? Microbial or clinical evidence of sepsis caused by a dysregulated host response. Your host is under some trouble, there is an external agent that is coming and troubling you, and there is some problem in the host body. Host body is the patient's body. So, as a result, the patient is having some issues. So, that is the first thing that you need to remember. So, that is regarding your sepsis. Next is anaphylaxis. We have already discussed the management of anaphylaxis and anaphylactic shock. So, I am not going for that. Now, high spinal injury. So, high spinal injury is again an example of an distributive shock. Again, what is happening here? Because of the cervical spine injury, imagine that there is a cervical spine injury, and as a result, the vagal tone is lost. So, when the vagal tone is lost, again, instead of vasoconstriction, there will be vasodilatation. So, there will be lot of pooling of blood in the periphery, and also since the vagal tone is lost, there will be usually hypotension will be associated with tachycardia, but here there will not be any evidence of tachycardia. It will be either normal heart rate or sometimes bradycardia with hypotension. So, that is the next thing that you need to remember. So, here you can have hypotension with bradycardia. So, where you can have hypotension with bradycardia can be a question in your MCQ test. So, remember that neurogenic shock. So, that is the time where you can have hypotension with bradycardia. See, there are two terminology that you will get confused, neurogenic shock and spinal shock. Both are not the same. Spinal shock is actually a misnomer. There is no shock. Neurogenic shock is the terminology that we need to use. Spinal shock is basically the state of the muscle. When somebody is having a weakness suddenly, the spinal cord and everything and the muscle will go into a state. So, that state of the muscle is called as spinal shock. So, there is no shock there actually. Okay. So, that is the first thing. Now, coming to hypovolemic shock, which we have discussed yesterday, the most common cause being dehydration, third spacing, that means in pancreatitis, it can go to the third space. There is no space like intracellular and extracellular space. There is something called as a third space. This water is getting shifted to a third space. The common example being dengue, and the next thing can be your pancreatitis and all those things. And there can be an external bleeding and sepsis also. See, when you see sepsis is a classical example for an distributive shock, but it can also cause hypovolemia because of shock. So, that just remember septic shock is ideally an example for a distributive shock. Now, coming to cardiogenic shock, in children primarily myocardial infarctions are not very common. So, whenever you are writing a cause for cardiogenic shock, the most common will be a myocarditis, cardiomyopathy or some arrhythmia or some congenital heart disease. So, here what will be the peripheries? The peripheries will be cold because there is no cardiac output. So, there is no good cardiac output. So, there is no blood is not reaching the periphery at all. So, the peripheries will be cold. Here also it will be cold. So, this is cold, this is warm, this is also cold. Now, coming to the obstructive shock, which we discussed for the adult patient, the common being cardiac tamponade, pulmonary embolism, tension pneumothorax and coarctation of aorta. So, coarctation of aorta is again one of the congenital anomaly of an aorta, where you can have an outflow obstruction, and as this will happen in neonates. So, soon after 1 day, 2 day baby that is coming to you, you are suspecting a coarctation of aorta, they can come with obstructive shock. So, just for your level, what you need to remember is that what are the different types of shock, how will you differentiate it clinically. So, how will you differentiate it clinically? Suppose a patient is having fever with hypotension altogether, it can be an septic shock. So, suppose the patient is coming with multiple episodes of diarrhea, loose stools and there is hypotension, it can be due to hypovolemic shock, also sepsis can be there because an infection can also, sepsis can also cause, it can be a combination of both, cardiogenic shock, cold peripheries. And next one you have to remember is tamponade, which is what we commonly we will discuss. Okay. Now, we will go to the one of the simple thing, basically what you have to do for a sepsis patient. This is a simple algorithm reproduced from your pals only. So, one thing that you have to do is that you have to early detection of the signs of shock. We need to very early detect the signs of septic shock. So, the most important can be increase in heart rate, or sometimes it can be decrease in heart rate also, but most commonly it is tachycardia. So, tachycardia, then capillary refilling time, then what can happen? See, capillary refilling time, as I told, see in septic shock it is a warm periphery, there are a lot of pooled blood in the periphery. So, when you are saying it shock, what will ideally should happen to the capillary refilling time? It should get prolonged. but here there is a lot of fluid in the periphery. So it might be in a minute, 1 second it will come back. Rather than a prolonged CRT, you are seeing a rapid CRT, that is called as a flash capillary refilling time. So when you see a flash capillary refilling time, because of that, it can be due to a septic shock. So flash capillary refilling time, it can be one of the reasons. It can be one is septic shock. And next thing you have to see is that blood pressure. Blood pressure, what can happen to the blood pressure? There can be hypotension. There can be hypotension, because if it is compensated, there will not be any hypotension. If it is not compensated, it is hypotensive shock, you will have hypotension. So that is the next clinical feature. So suppose you have got a patient, you need to suspect all those things. The next thing, that initial stabilization, as I told, ABCD stabilization is the crucial. You have to get an IV access or an IO access. IO access we have covered. How to do an IO access we have discussed in the last class. So IO access we need to go ahead. And next important thing is that you have to get blood samples. You have to take blood samples, whichever is the priority depending upon the patient's presentation. You have to take maybe your electrolytes, your complete blood count, maybe your blood culture and all those things. So stabilize the patient. And fluid bolus, the most important one is the fluid bolus, isotonic crystalloids. So yesterday I told isotonic crystalloids, or we can call it as balanced crystalloids, 20 to 30 ml per kg. You can remember 20 ml per kg. You can give it over very fast if there is hypotension. You can give within next 10 to 15 minutes. Or if there is very borderline blood pressure, maybe within 30 to 40 minutes. But when you suspect that this child is having a cardiac failure, so don't pump in more fluid. So 5 to 10 ml per kg is what we need to do when you suspect the child is having an underlying cardiac failure also. Then antimicrobial within 1 hour. As I told, 1 hour they are saying because there is shock. If there is no shock, within 3 hours is also okay. Okay. Then you have to frequently reassess the patient, see how the patient is. Then you can have two types of patients. One is resolving. The patient is doing well, hypotension has improved, capillary refilling time, hypotension, the sensorium of the child has improved, everything. So that is resolving signs of shock. Now when you come to this side, you have given one pine bolus, one more pine bolus. What you can say that this patient is having a fluid refractory septic shock. General septic shock, you know what is it? Refractory means after one treatment the patient is not improving. But what treatment we are given? We are given fluid. So that is the name why we are given is fluid refractory septic shock. So this child is having a fluid refractory septic shock. So you can have two things. You can have a patient with shock. You understood this here? You have to be very clear. The patient is in shock. So one is hypotensive and compensated. So hypotensive, what you are given? You are given IV fluid bolus. From here you can have two possibilities: responding, refractory. Okay. See, as I told, septic shock might not be the only one culprit. It can be in combination with cardiogenic shock also. So you can have a patient. How will you differentiate that whether there is an associated cardiogenic? See the periphery. See the periphery. If the periphery is warm, you are dealing with probably a septic shock alone. The periphery is cold, you are dealing with probably with a patient with septic shock along with a cardiogenic shock. So that is how you have to differentiate. Suppose you have gotten refractory here, you can have warm peripheries and cold peripheries. So if it is warm peripheries, as I told, what is the treatment? The treatment option is norepinephrine, noradrenaline. The dosage ranging from 0.05 to 0.3 microgram per kilogram per minute. So if it is a warm shock, the treatment is what? Noradrenaline. But if it is a cold shock means what is that? You have cardiogenic shock also associated. So we need to give a drug that will increase the heart rate as well as which can increase the venous return also. So we need to select a drug. Noradrenaline will not increase the heart rate. So what you have to give, you can use this drug is epinephrine. So for those group of patients, you can give epinephrine. This is just pediatrics. Don't confuse it with adult patients. So what I am discussing here is just pediatrics hypotension management. So the drug of choice for shock with cold extremities is epinephrine. The dose being ranging from 0.05 to 0.3 microgram. The same dose what you can remember, 0.3 microgram per kilogram per minute. So, that is what you can give is noradrenaline and adrenaline infusion. So, that is the next thing that you can remember. So, what we have said, depending upon the patient's periphery, whether we are dealing a cold shock or a warm shock, or else if you do not have norepinephrine or epinephrine, alternatively you can use dopamine also, 5 to 10 microgram per kilogram per minute. So, that is an alternate regimen that you can use. Then this patient should be shifted to the ICU, all those things. And if the patient is still having hypotension, okay, you are given one vasopressor agent. So, vasopressor agent you have started, but still having hypotension, then that is called as refractory septic shock. The other one what I told is fluid refractory septic shock. When you just say refractory septic shock, what does it mean? You have started one vasopressor agent, fluid bolus already given, vasopressor already started, but still the patient is having hypotension, then you can give, you have to suspect there is something called as adrenal insufficiency, because there can be suppression from the adrenal. So, adrenal gland is very important. So, this sepsis can affect the adrenal glands also. So, as a result, the cortisol production may not be there. So, if the cortisol production is not there, what do you have to give? You have to give a drug called as hydrocortisone. So, basically septic shock management, one, you have two types of patient. You can have compensated shock and two is hypotensive shock. So, for any of these things, most important one is first is lactate measure. If there is hypotension, give IV balanced crystalloids. Third one, if the patient is having, you have to draw blood culture and broad spectrum antibiotics. So, this is same for all these two group of patient. And if there is hypotensive patient, so what you have to do? You have to give IV fluid bolus, 20 ml per kg you given, see the response. If it is refractory to the fluid, what do you have to say? Maybe you can give one more bolus, sometimes you can give one more bolus and you can start on norepinephrine if it is a warm shock, epinephrine if it is a cold shock, or you can start dopamine. Okay. So, this part is clear. So, even after this there is hypotension, refractory shock, refractory septic shock, you can give hydrocortisone. So, otherwise it is called as catecholamine resistant shock. So, that is the other terminology what we can use is catecholamine resistant shock. You are given a catecholamine agent, either epinephrine or norepinephrine, but still the blood pressure has not improved. So, that is how we have to manage your septic shock. So, that concludes our discussion on shock management. So, remember that shock management is pretty simple, there is no complicated things. You can have the most important reason for shock in a child is dehydration. Always it is dehydration. Dehydration can have two types. You can have any hypotension or any shock can have two types. You can have a compensated or hypotensive shock. What is the criteria that you need to remember is whether there is hypotension, it is hypotensive shock. Whether there is no hypotension, it is compensated shock. Classification: distributive, cardiogenic, hypovolemic, and you can have obstructive shock. In distributive, you have septic shock, anaphylactic shock, and also you have the neurogenic shock. In hypovolemic shock, the most important reason is dehydration, and you can have blood loss also. Hemorrhagic shock also is there. Then you come to this side, obstructive shock causes, we have said, tamponade, pulmonary embolism, pneumothorax and cortication of aorta. And on the other side, you have cardiogenic shock, the most important reason being myocarditis. So, that is in a nutshell regarding your treatment. So, if the patient you have suspecting a cardiogenic shock, do not go with an high bolus, you give with 5 to 10 ml per kg and you assess the child, look for crepitation. Depending upon that, you give further boluses. If you are confident that this child is not having any cardiac issues, go with 20 ml per kg. So, that is what you have to remember. So, we have concluded all our PALS lectures. So, next week we will have the assessment exams. So, that date I will announce. Okay. Thank you.